The patient is a 52-year-old homemaker and is vegetarian. Her chief concerns is ill-fitting and uncomfortable bridge works done by other dentists 5 years ago. She would like to redo her dental works definitively and is interested in dental implants but has a limited budget. The patient has hypotension but otherwise has a clear medical history and is not on any medication. Examination shows that there is a failing upper and lower bridge work with occlusal discrepancy. The upper teeth 15, 13, 12, 11, 21, 23, 24, and 27 serve as abutments. Unfortunately, they have questionable integrity. There is a slightly lower facial third of face due to the collapsed bridgework. She has fair oral hygiene but difficulty in maintenance due to the failing bridgework. The BPE has been recorded as a score of 2. Her arch is small and narrow, and the focus of this case is the endodontically treated 3.5 and 3.7, which is still symptomatic. They are tender to percussion and they feel strange when biting. Diagnosis reveals an inadequately root-treated 3.7 and 3.5 with marginal leakage and caries. There is also a discrepancy in occlusion where the top and lower bridgework does not meet well. Discussion of treatment options are all listed in the write-up. The definitive comprehensive treatment plan would involve caries control and supportive periodontal therapy to improve oral hygiene. The rehabilitation of the upper arch has been started and eventually will be turned into a fixed implant bridge. Exploration and sectioning of the lower left bridge was done, and the old post and pins in tooth 3.7 was removed with mosquito forceps. Endodontic retreatment of teeth 3.5 and 3.7 were then carried out with root canal sealant remover, Gates-Glidden files, K-files, headstroms, with copious amounts of EDTA and sodium hypochlorite irrigation. The K-files were bent at the tip to aid in the mechanical removal of the old GP cones. I have managed to remove almost all GP except the ones in the distal root of the 3.7, in which a size 20 file has been used to manage to bypass the GP towards the root apex. Both teeth were then dressed copiously with calcium hydroxide dressing, and mechanical and chemical preparation of the root canals of the 3.5 and 3.7 were done as if it were a routine endodontic treatment using the ProTaper protocol. However, the torque of the rotary files are kept low below 1.5 newtons to minimize the risk of not only file breakage but root fracture of the long-standing, brittle, non-vital teeth. Coronal preparation of the two teeth also included ultrasonic scalar tips. Pure calcium hydroxide is then dressed and provisional pro-tem crowns are used on the 3.4 and 3.5. The 3.4 is vital and they are splintered for the time being. They will then be sectioned off towards the more definitive stage of restoration. The 3.7 is only provisionalized with Cavit and glass ionomer cement, and it serves as a non-functioning tooth for the moment. It will later be utilized as an abutment tooth. The penultimate dressing is pure calcium hydroxide, which was left there for 2 weeks, where its extremely high pH creates an unfavorable environment for the remaining microbes that's left in the root canals of the two teeth. Once the teeth are symptom-free, the choice of root canal sealant and gutta percha is made. We use a self-priming resin-based canal sealer, which is methacrylate based, and it relies on chemical bonding rather than heat or pressure to fill the canal. This would lower the risk of the addition of root trauma or fracture on the already brittle teeth. Rubber dam isolation was not possible, not only because the patient's dental arch is extremely small, but placement of rubber dam clamps on such broken down tooth is impossible. Therefore, a compromise is made. The dental assistant has to diligently manage the saliva ejector well for moisture control. After the canals were dried with paper points, the verified length of the custom navigational tip syringe of the sealant was chosen and apically delivered. It is inserted 2 to 4 millimeters short of the apex of the teeth. The sealant Endorest contains a special hydrophilic organophosphate methacrylic monomer that increases its hydrophilicity and produces a resin with a strong affinity for moisture with resin penetration of 1,200 microns into the tubules. This would improve the prognosis of the distal root where the retained GP is still present. The master GP are then inserted and a passive apical tightness is felt. The sealant is left to set around 20 to 30 minutes and the extra unwanted gutter perches are then sheared off. They are then restored with Cavit and glass ionomer cement. The re-endodontic treatment has been completed and the teeth are now waiting for a new 3-unit bridge.